Thank you all for joining us today. We are right at 4 o'clock, so if we will go ahead and get started. Welcome everyone. My name is Erin Stagletter. I'm the Education Manager for the Virginia Breast Cancer Foundation. Today we'll be hearing from Dr. Emily Bellavance from the Virginia Cancer Institute, followed by Casey Young from CancerLINC. The panelists will be taking questions after both of the talks have been completed. So you're welcome to enter any questions that you have in the chat box, and you can direct them to all panelists or all panelists and participants. You can do this throughout the webinar so you don't forget your question. We will begin with Dr. Bellavance. Dr. Emily Bellavance is a fellowship-trained breast surgical oncologist at Virginia Cancer Institute with years of experience in the treatment of benign and malignant breast disease. She received her medical degree from the University of Maryland School of Medicine, where she later became a resident in general surgery. After completing her residency, she was a fellow at the University of Chicago Pritzker School of Medicine's Surgical Oncology Department, where she also completed a fellowship in medical ethics. And she'll be focusing her talk today on metastatic breast cancer. With that, Dr. Bellavance, you can share your screen whenever you're ready.
Thank you for that lovely introduction. And I'm almost there.
No worries.
I'm a little bit of a Luddite with this. Okay, with the Zoom talks. So thank you so much for allowing me to discuss metastatic breast cancer today. This is, a very important subject to me, both professionally and personally. My mother's youngest sister died of metastatic breast cancer when she was 36. And, for obvious reasons, this had a big effect on the whole family, probably affected my decision in what area I wanted to specialize in medicine. But I think on a more hopeful note, I'm often in awe of how much the treatment has changed when she went through treatment for that disease in the mid-70s. And just in my lifetime, basically everything is different, and there are a lot of really good things happening in this area. So just for a brief overview, I'd like to just review a little bit about the epidemiology or the status of breast cancer in the United States. I do want to recognize the advocacy involved, especially as it relates to educating the public and supporting patients with metastatic breast cancer. And then we'll get into some of the advances with targeted therapies and where we might be going in the future. So breast cancer is the most common cancer that affects women in the United States. So in 2020, there will be about 270,000 cases diagnosed. This translates into a risk of about 1 in 8 or 12.5% lifetime risk for women. And so many of us, if we have not already been affected by this disease, either if there are people listening who are patients, or we will probably eventually be affected either with a loved one or a friend or somebody in our neighborhood. It is the second most common cause of cancer death among women, and the majority of these deaths will be caused by metastatic breast cancer after it travels beyond the breast to the other organs in the body. However, as I mentioned before, the outcomes for breast cancer have really improved tremendously over the last several years. And this is true for all stages. So from the large
Dr. Bellavance, we seem to be losing you a little bit.
Okay, let me see if I can.
Okay, I got you back.
Okay. So essentially, the improvements in breast cancer outcomes stage for stage is largely attributable to the advances in medical treatment as well as improved screening modalities. So more women getting screened, but also the technology has improved for screening for breast cancer. And this improvement in survival has also translated into improvements for metastatic disease, particularly among younger women. And this is, again, data from a large national database showing that in the 1990s, between the 1990s to 2012, the survival rate has doubled for this age group. However, we could also argue that a 5-year survival of 36%, with that, we still have a lot of room to grow and improve these numbers. Now, the number of women who have metastatic breast cancer, now it's a little bit hard to estimate because our national databases, which collect data on newly diagnosed cancer patients, they only record a metastatic case if that is how the patient initially presents. And the majority of metastatic breast cancers actually occur as a recurrence of a disease. So a patient may have had an early stage disease and then several years later, unfortunately, the cancer came back and started to spread throughout the body. And so this is data from an interesting paper, which essentially uses a mathematical model to estimate the number of women in the US with metastatic breast cancer. And these numbers are derived from our patients who present with this disease, but also estimations on how many will have a recurrence and what their outcomes will be once that recurrence is diagnosed. So in 2020, we estimate over 160,000 women are living with metastatic breast cancer. And similarly, using mathematical models, we can also estimate how long women have been living with metastatic breast cancer. And while we see our greatest number in this dark green, 40%, has been living with it for only 0 to 2 years, there's a significant proportion of women. In the light blue, we have 17% who have had metastatic breast cancer from 5 to 10 years, and then the light green for over 10 years. This essentially speaks to, I think, a very interesting aspect of this disease, in that there's a subset of patients who have a very favorable prognosis, who can live many years. And so, given that there are so many women and many of them have been living with this for many years, this gives rise to another aspect I'd like to address, which is breast cancer advocacy, particularly within the metastatic breast cancer group. And I suspect some of this advocacy has led to picking this topic for discussion. Now, traditionally, Breast Cancer Awareness Month and many of our nonprofit organizations have focused on early detection and celebration of our survivors. Some of the even commerce surrounding breast cancer has focused on early disease and quote unquote beating cancer. And certainly a lot of the articles in the popular press focus on patients with early disease or undergoing surgeries to prevent breast cancer. And you can imagine for patients and women who have metastatic breast cancer, it might be sometimes difficult to have this emphasis always on early cancer and prevention. And so there's definitely a need for increased support, education, and research funding in this area. So I would say for about the last decade, there's been a push to put more emphasis on metastatic breast cancer, recognize that the goals of treatment are a little bit different than an early stage patient. The treatment is going to be continuous. Its goal is to extend life while minimizing symptoms rather than an isolated time of intense treatment to reach for a cure. Traditionally, in terms of all cancer funding, this is largely focused on early stage disease, and there really is a need to increase funding to extend lives of patients who already have a more advanced disease. And so this advocacy has also supported this initiative. And certainly played a large role in providing support, dedicated support for metastatic breast cancer patients who have different needs. And so in addition to the Virginia Breast Cancer Foundation, which of course covers all stages of disease in terms of their advocacy, there have been a couple of other nonprofit groups that focus specifically on metastatic breast cancer. And these can be really helpful resources for patients, either for online support, especially now when we can't meet in person for our support groups. But again, also work for that increased research funding and education of the public. And about 10 years ago, actually, a group of patient advocates in New York proposed that New York State make October 13th National Metastatic Breast Cancer Awareness Day, and that was passed. And this legislature has also passed on to a lot of other states have followed suit. So on October 13th, we also recognize, among other days, our patients with or metastatic breast cancer. Now I'd just like to get into the more nitty-gritty portion of the talk when we discuss our advances in treatment. So just for the purposes of this talk, I'm just going to distinguish between localized breast cancer, screen left, which would include stages 1 through 3, in which the breast cancer is confined to the breast tissues and the draining lymph nodes in that area. And so what we're focusing on is metastatic breast cancer, is stage 4, and that by definition means that we see gross disease outside of the breast in those regional lymph nodes. And normally most commonly breast cancer will metastasize to the liver, the lungs, the bone, or the brain. And so our treatment for localized breast cancer, our backbone of treatment is going to be local treatment, so which includes surgery and radiation. And we always use, in this setting, systemic therapy, which would include chemotherapy, endocrine therapy, which are pills to lower the levels of estrogen, and what we call targeted agents to prevent the development of gross metastatic disease. So in a patient with early breast cancer, we use systemic therapy to treat microscopic disease that we can't see on our scans, that if left alone would develop into true metastatic breast cancer. And again, the goal for a treatment for localized breast cancer is a cure. For metastatic breast cancer, our backbone of our treatment is going to be systemic treatment because we know that the cancer is already spread throughout the body. But we can also use surgery and radiation, either surgery to remove the primary tumor or help with symptom control. And similarly with radiation, this can be used in select situations. So for example, it can be very effective to treat brain metastases, or we may use targeted radiation to treat bony metastases that cause pain. And the goal of treatment is different than for localized breast cancer. Again, our goal is to extend life and for symptom control. So essentially, the treatment for a metastatic breast cancer patient is likely going to include multiple specialists, not everyone on this screen for every patient. So our ringleader is going to be our medical oncologist. And again, as I mentioned before, the patient might need a surgeon or a radiation oncologist. But there are multiple other areas of specialized support that can be helpful, including a palliative care specialist to really focus on treating either symptoms from the disease or symptoms from the treatment. A nurse navigator can help in coordinating all the different types of specialists available to the patient. Certainly our oncology nurses are critical on an everyday basis. And I'm sure Casey will speak to this later, but a financial counselor can be very helpful. Sometimes, especially in these long-term treatments, there could be a financial burden either with missing work or with additional copays with treatment. Now, when we see a patient who presents with metastatic breast cancer, our treatment is going to be guided by several things. One, of course, will be the health of the patient. What can she tolerate? Very importantly, we need to consider not just the goals of treatment from a medical standpoint, but also from the patient's perspective. And this, of course, can be something as simple as, I can't start my chemotherapy until next month because I need to go to my sister's wedding and I want my hair to look good. To, you know, we need to do everything possible to keep me alive so I can see my kids grow up. We also direct our treatment based on the extent of metastases, so the extent of disease. And what's very important is the specific type of breast cancer. And so in breast cancer, many breast cancer cells will express up to 3 receptors, which are very important in determining what stimulates that cancer to grow. So if you look on screen left, I have a pink cell there with 3 different receptors. I guess I can't use my arrow, but on screen left, we have a green receptor, which is the HER2/neu receptor, and that means that the cancer is stimulated by this protein our bodies have called HER2/neu. It stimulates this growth. And then we have our hormone receptors. In the black are estrogen receptor, and the orange are progesterone receptor. And this means the cancer will be stimulated to grow based off our circulating hormones, such as estrogen. There are also some cancer cells that do not express any of these receptors, and this is called triple-negative breast cancer, which is our most aggressive type of breast cancer, in part because it's very difficult to find therapies to target the treatment because we have no growth receptors to target. Now, the majority of breast cancers in the United States are hormone receptor positive, so that's that big pink piece of the pie. So that'll be about 75 to 80% of new cancers that present. About 20 to 25% will be HER2 positive, and only about 10 to 15% will be triple-negative breast cancers. And it doesn't quite add up to 100% because some patients will have, again, all 3 of the receptors, or they might just have the HER2 receptor, but not a hormone receptor. And so I'd like to just go through 2 cases to illustrate some of the different ways we can treat patients. And in both of those cases, I'll be talking about some specific advances or newer options. And so for our first case, we have a 42-year-old woman who presents with, she noticed a mass in her left breast. She was also complaining of some rib pain. And so, of course, she underwent some imaging studies of her breast, starting with a mammogram and ultrasound, and then a biopsy. And this is a picture of her breast MRI, and we see in her medial left breast, this white area is her tumor that's circled with the yellow mark. And then on her biopsy, she has the type of breast cancer that responds to all 3 receptors. So we have 3 areas to target for her treatment. Because she complained of rib pain, we also performed an imaging study to look for disease elsewhere, and she did in fact have an isolated rib metastases, which you can see in the dark area on this bone scan. And so in this young patient with just 1 area of metastases, we're going to treat her very aggressively. Some would say for cure. That is controversial to call aggressive treatment for metastatic breast cancer for a cure. But regardless, we're trying to get her to a place where we cannot detect any more disease on her imaging at the end of treatment. And so we know that the cancer has passed beyond her breast and her lymph nodes. So we're going to initially focus our treatment on her whole body with medical therapy. And we will start our focus with that HER2/neu receptor. And so her initial treatment will be a combination of chemotherapy and anti-HER2/neu antibodies. And this treatment will last about 5.5 months, every 3 weeks. even though we have this receptor to target with the anti-HER2 new antibodies, we can't really use that alone. It appears that it will only work very effectively if we add on the chemotherapy with that treatment. And the way these antibodies work is that they essentially will bind to that receptor, so it blocks the ability of the HER2 new to stimulate growth. But because they're antibodies, they will also then signal our immune system to start to attack those cancer cells as well. So they kind of have a dual action. So when she completed this treatment, we're going to re-image her breast as well as her the area of her bone metastases, and you can see here on her MRI that the tumor is much smaller, although there is some residual enhancement there. And on her repeat bone imaging, there was no visible disease. So this is what we would consider an excellent response. So she then underwent surgery to remove the mass and assess her lymph nodes. We would complete this with radiation to the breast to treat the rest of the breast tissue because she had a lumpectomy or breast conserving surgery. And then we would complete her antibody therapy for the rest of the year. Once this is complete, now we have another target to focus on, and that's going to be the hormone receptors. So she will then be able to go on to endocrine therapy with a pill to block that receptor, either block that receptor or lower the levels. There are others that lower the levels of circulating estrogen. And because she has initially presented with metastatic disease, she will be on that therapy indefinitely with intermittent scans to assess for progression. So this is a case from about 5 years ago. So what would we do today? So we could do, there are a couple things available to us today that we might do differently. And one is the use of what we call antibody drug conjugates. And essentially, this combines that specificity of the HER2 new antibody, which is called trastuzumab. So that would have been in her initial treatment. And attached to this antibody is a chemotherapy agent, DM1 or MTANC. So normally when we give chemotherapy alone or not attached to an antibody, it's going to affect the whole body and just, you know, it kills other cells, which I'll get into later. But this is a way to actually deliver that drug directly to the cancer cell. And so the chemotherapy that's attached to the antibody will bind onto that receptor, get incorporated in the cell, and then the chemotherapy agent will be released into that cell. And so there are a couple trials with the use of TDM1, the antibody drug conjugate, both in metastatic breast cancer and in earlier stage disease. So on screen left is just a graph demonstrating that in patients with metastatic breast cancer who have been previously treated with the antibody therapy alone, if they progress and add on this TDM1, they have increased survival compared to patients who aren't given that opportunity. And then on screen right, anytime we see a medication that works well in the metastatic setting, we also like to see how well it works in an early stage setting. And this is essentially the addition of TDM1 in patients who have had chemotherapy and immune therapy up front. Their tumor shrinks, the tumor's removed, but there's still residual disease. If you switch over to this TDM1, then you get about double the progression-free survival. So essentially double the time until you see the cancer appear again. And so I would argue that even though this patient I presented initially had metastatic disease, we may have actually used this earlier on in her presentation. But it can still be helpful to her if she, in the future, at some point, develops progression. If we see her develop a new lesion, then this would be in our armamentarium to use to try to stave off that disease. Now, there are multiple areas of development for these antibody drug conjugates. So again, just in December, the FDA approved an additional HER2 new antibody drug conjugate called trastuzumab deruxtecan. And this is essentially a graph that shows the response of individual patients. And so this was used in patients who had been previously exposed to TDM1 and had progressed. And this is a very difficult patient population to treat if they've had multiple treatments and the cancer is still growing. And on screen left, if you see the bars going up, those are the few patients where the tumor kept growing. And the rest of the bars are essentially the percentage represent for each patient how much their tumor responded. So the overall response rate for this was about 60%, which is unheard of in this patient population. Usually it's something around 15 to 30%. And the duration of the response is very impressive, about 15 months. Again, very unusual in this patient population. And so there are multiple areas of development for this type of medication. Currently, there are over 90 antibody drug conjugates in testing for cancer treatments, and not just for breast cancer. There are some new technologies which can enable that chemotherapy drug or that cytotoxic drug that we're sneaking into that cancer cell to also affect surrounding cancer cells that might not express the HER2/neu receptor. This is called the bystander effect. And then there's also some studies ongoing to look at the effect of this agent in maybe cancers that have a very low HER2/neu expression. So ones we might not think would respond as robustly. So let's go on and just discuss a different type of case. So this is our second case is a 55-year-old woman who presents with abdominal pain and back pain. She undergoes a CT scan, which unfortunately shows areas concerning for cancer in her liver, lesions in her spine, and a small right breast mass. She undergoes a biopsy and it demonstrates breast cancer. And this is the type that's a triple negative cancer. So it appears at our initial assessment that we don't have one of those receptors to target. And because there are several areas of disease throughout her body, we are really going to focus on the medical therapy here. There might be a time where radiation or surgery is relevant in the future, but for now, the mainstay, again, is going to be the medical therapy. And traditionally, we would treat this type of breast cancer patient with what we call single agent chemotherapy and sequential single agent chemotherapy. So up until probably the 1990s, the standard of care for these patients would be just to hit them really hard with multiple different agents. And that could be, that could have a lot of morbidity. And obviously, if you're getting a lot of chemotherapy agents at one time, that could be tough to go through. But it wasn't until really maybe 2000, 2002, where a very important landmark study was published, which just basically compared using one single agent alone versus using multiple agents, and the patients lived the same amount of time. So that was really a good turning point in our treatment, that we could minimize some of that toxicity and just use one agent after another. But of course, the downside to chemotherapy, again, is that it's not targeted. So it essentially is killing cells in our body that are rapidly growing. So this includes cancer cells. So it's very effective in killing cancer, but it also kills some of our other healthy cells. So it can affect hair loss. Our hair cells are always growing. It can affect our blood counts because our bone marrow is continuously turning over its production of red blood cells and white blood cells. It can cause symptoms in our gastrointestinal tract because the lining of our intestines tends to turn over very rapidly. And also it can commonly affect some of our peripheral nerves, so with numbness and sometimes pain in the feet and legs. And so for triple negative cancers, there's been an increasing interest in, again, using our own immune system to help us fight the cancer. And this has been of particular interest in the triple negative breast cancers because it tends to be immunogenic. So it appears to attract our immune cells in that kind of milieu surrounding the tumor. And in general, immune therapy has become a very increasing importance in cancer research in general. And on the screen right, you can see that the majority of clinical trials now are focusing on what we call T-cell targeted immune modulator in the setting of metastatic disease. And so I'd like to talk about one of those agents that we could potentially use in this patient. And that is what's called a PD-L1 inhibitor. So if you can just bear with me, taking you through this slide. On the top portion of the slide, the top picture, you can see a tumor cell on the right side and a T cell. So one of our immune cells that it's going to want to attack that tumor cell because the tumor cell is abnormal. However, some of these tumor cells can be pretty sneaky, and they will express this protein on their surface called PD-L1. So that's the blue Y you see towards the bottom. And the PD-L1 receptor will bind with the PD-1 protein on the T cell. And that interaction tells that T cell to back off. It tells the T cell just to, immune system, calm down, everything's fine, don't attack me. And so the purpose of the PD-L1 inhibitor is essentially to stop that interaction so the T cell is allowed to recognize that tumor cell as something that can be dangerous to us and initiate that immune cascade to start fighting against the cancer. And these have been shown to be very effective in the treatment of triple-negative breast cancer, particularly in those cancers that express that PD-L1 protein. And so this is just data from a recent trial that shows that if you add this PD-L1 inhibitor, so atezolizumab, to one of our traditional chemotherapies, paclitaxel, you can see an overall response rate of 60% versus 42%, which we would see in the chemotherapy alone. And the patients who have this additional PD-L1 inhibitor have a longer period of time without progression, and their overall survival is likewise improved, particularly in the group that expresses the PD-L1 receptor. For all patients, you can't demonstrate a significant overall survival difference, but in those patients who express that PD-L1 receptor, you can see a difference in overall survival. And so what's next in this area of PD-L1 inhibition? So different current areas of investigation is to, one, combine the inhibitor with something called induction therapy. And all that means is that instead of, you're just basically using a shorter course of chemotherapy. So again, to try to minimize those side effects while increasing your targeted therapy. So there appears to be some complementary interaction between the chemotherapy and the PD-L1 inhibitor. But if we could maybe just shorten that course of chemotherapy to the beginning, kind of get that interaction going and follow it up with the PD-L1, that would be great if it were just as effective. Similarly, radiation has been shown in certain situations to stimulate the immune system. So there is some interest in combining radiation and these inhibitors. And again, as before, whenever we see something work very well in the metastatic setting, we want to see how well it will work in earlier stages. So there are some trials ongoing looking at using this in neoadjuvant therapies, and also applying the PD-L1 inhibitors to other types of breast cancer, so other cancers besides triple-negative disease. And we have one such trial open. It's a national trial, so it's open across the country in multiple different sites, and we're one of those sites. And the purpose of this trial is to investigate the use of that PD-L1 inhibition for HER2 positive breast cancer. And so patients eligible for this type of treatment would be either patients who present with HER2 positive metastatic disease or with locally recurrent disease that can't be removed with surgery. And so half of those patients would be randomized to our standard treatment, which you see on the bottom screen right, which would be our chemotherapy agent and our two anti-HER2 antibody agents. And half of those patients on the top of the screen right would be randomized to the chemotherapy, anti-HER2 new antibodies, and our PD-L1 inhibitor. And the purpose of the study would be to see our percentage of patients that respond, and also how long can we go without evidence of progression. And so this is just to remind myself, to remind you that thus far, I've really only discussed a handful of advances. And so really it's the tip of the iceberg. There are multiple other therapies that have been improved or on the cusp of being improved, which targeted different pathways in cancer progression and have been shown to be very effective in improving our outcomes in the metastatic setting. But my final topic is I'd like to get into what I think we'll be seeing in the future. So thus far, I've been discussing essentially what I would describe as kind of a personalized or precision move towards more personalized and precise medicine. So it's personalized in the sense that, you know, we need to look at the clinical picture of each individual patient and their different goals with the therapy, but it's also personalized, and we're trying to find very specific mutations in their breast cancer that we can target to avoid normal cells and attack the cancer cells with targeted therapy. And another way to take this idea of personalized medicine and targeted therapy a little further is with something called next generation sequencing, which is essentially a high throughput sequencing of DNA that allows us to determine mutations in DNA and RNA quickly with less expense. And let me just put that less expense and time in perspective. So the Human Genome Project, which was essentially a project with sequencing the entire genome of a human, took about 10 years with the traditional method and $4 billion. So that was completed, I believe, in 2003. So this is a method that might cost perhaps $2,000 or $3,000 and can be processed in a week or 2 weeks. And so the advantage of this next generation sequencing is, number one, it's a huge advantage in progressing our research, because the more targets we can identify that are abnormal or have more mutations in these cancers, then we know the more opportunity for drug development we have, essentially. It can also be very helpful in assessing the genetic risk for cancer. So we have several genetic tests available that detect DNA mutations by a method called genotyping, and it's very effective, but you essentially need to know exactly what mutations you're looking for with those tests. And just to put it in perspective, a broad spectrum genetic test that we use now might be able to test perhaps something like 300 or 300 genes, and we're talking about testing thousands. Sometimes that could also be unhelpful. You can imagine if we have a bunch of abnormalities that we have no idea what the significance of this means. And finally, this can be important in identifying mutations in the tumor, again, to try to identify therapy specifically targeted to that cancer. Now, this diagram is a little bit outdated, but I'm going to go through the most traditional use for next generation sequencing, and then probably, and then more commonly, how we would use it today. So this has been used in the clinical setting. It is often restricted to patients, in terms of breast cancer. There are some other cancers where it's used a little bit more liberally. It's was traditionally restricted to patients who have been progressing on traditional therapies. Like each therapy we give them, the cancer seems to grow. And then we would kind of petition the insurance company to approve this next generation sequencing in the hope that we could find a target. We could find a target that could be effective to that specific mutation. I would say maybe that was the indication 1 to 2 years ago. Now, I think it's being used much more frequently early on for a couple reasons. It's in the metastatic setting, not necessarily in early disease. So rather than trying to send off a different test for each mutation that you're looking for, you can send this off early on and get your information right away. And secondly, there are a lot of trials open now that this is part of their initial criteria to get into the trial. So it often can be sent off to see if a patient is eligible for clinical trials. There are limitations. So this is, again, something that's used selectively. One problem I sort of alluded to before is that a lot of the actionable mutations can be tested by other means. So if you send off a next generation sequencing test, you could find a PD-L1 expression, but you could also send off a specific test towards that. And that's going to be, again, less expensive and more specific. You're not going to get a whole slew of results. There are several actionable mutations, but not as many as you would think, given the amount of data you can get initially. There's certainly a large infrastructure required to store and analyze the data. And so this requires centralization, essentially, to contain the costs and have the specific manpower to do this. And so these tests are sent off. There are a handful of different companies that can process this information. I would say it's still unclear what the best tissue is to use. Some tests use our blood, circulating tumor cells. Should we be biopsying the metastatic focus of the primary tumor? And with any type of test that uses genetic information, there can always be concerns over privacy and the use of specimens. And I would say this actually comes up a lot in some of our older clinical trials where you might have had, let's say, a trial on leukemia that ended 5 years ago, but now we have new data that there's a specific drug that could potentially treat a specific mutation, and you have all of these specimens that were stored from that trial, but nobody anticipated that we would have this technology to test the specimens. And so none of those patients have been consented for this additional genetic testing. And this can be a problem because even if you try to reconsent those patients, they might not be available. Maybe the trial was for a particularly aggressive disease and many of those patients aren't alive. And so oftentimes these are questions that can be brought up, need to be reviewed by either institutional or kind of these national groups that do trials for review to see what the best way to proceed is. And sometimes it's you can't do the test. And so in conclusion, I hope I've conveyed that there have been a lot of advances in the treatment of metastatic breast cancer and a lot of advances to anticipate. Essentially, there will be a change in our treatment paradigm about every year, which is incredible. Treatment of metastatic cancer involves a team of specialists. It should be personalized to the patient's goals, the type of cancer, and extent of disease. And advances in breast cancer treatment are going to include the development of more targeted therapies, essentially to increase the efficacy of treatment and minimize the side effects. And the two ways we talked about today are utilizing our own immune system and targeting other pathways. And hopefully we'll continue to move forward towards an increasingly personalized and individual approach with some of the technologies we discussed, such as the use of DNA sequencing. And with that, I would like to thank everyone and take questions. I don't know, take questions if that's what we're supposed to do.
Dr. Bellavance, I think we're going to wait until Casey does her presentation to take questions. So please stick around, but thank you so much. That was really informative and also clear. So that was wonderful. Thank you. So Casey Young is our next speaker, and she currently works as the Outreach and Communications Manager for CancerLINC. She graduated from VCU with a Bachelor of Science in Mass Communications with a concentration in broadcast journalism and a minor in business. Casey is doing some great work around outreach on their resources for CancerLINC. So Casey, whenever you're ready, you can share your screen.
Thank you so much, Erin. I'm so excited to talk about CancerLINC and our resources. So again, my name is Casey Young. I am the Outreach and Communications Manager for CancerLINC. So let's jump right to it. Okay. So CancerLINC, we are a Central Virginia-based nonprofit. And what we do is we connect cancer patients to legal, financial, and community resources to cancer patients and their families for no charge. And how we do that is that we connect cancer patients to volunteer attorneys, financial planners, and other professional services who are provided on a pro bono basis to help these cancer patients address the problems they may face, whether it be eviction, bankruptcy, employment issues, and other similar situations. We provide a very basic human need, and it's a service that we see that is needed not just in the Commonwealth, but probably in the whole nation. So I'm going to be talking a little bit about our history, our outreach services, a few legal problems cancer patients usually face, how help is provided, and then I'm going to talk a little bit about our statistics with our clients, our services, and then our other resources. So CancerLINC was actually founded by two local graduates from the University of Richmond, both graduated from the law school back in the 90s, and both of them actually had cancer. And so when they were going through their treatment, they had the question, well, how does somebody figure out insurance claims, time off of work, things like that when they're dealing with a cancer diagnosis? And so that's when they came up with CancerLINC. And we were founded back in 1996. And so we are 24 years old. And within those 24 years, it is estimated that we have helped over 10,000 cancer patients and their families. So we are very excited about that, to help as many cancer patients as possible. And to our knowledge, there is no other organization in the Commonwealth that provides the same set of services as we do. So I'm going to talk a little bit about our outreach services. So we do have a medical legal partnership with VCU Massey Cancer Center, where we do have our client services attorney on site to help those patients there. We also provide life planning clinics, which are free to our clients. And what happens there is that we have attorneys, and they will come and they will help clients with wills, advanced medical directives, and durable power of attorneys. And what is really good about this service is that they will get these papers finalized in hand as they get it done. So that is very awesome. And we are also a part of a speakers bureau. So we receive event invitations and we go and we do talks about our organization. So just to talk about a few legal problems cancer patients may face. I'm going to talk about employment problems, housing problems, a few other on my next slide. So what we see a lot of the time, we see a lot of loss of employment. So that also means a loss of insurance coverage as well that comes with that. And then we see it's a cycle. It's an illness, unemployment, poverty, the loss of insurance, and these bills they're still increasing, they're still coming. People are still trying to get better, and then with that, potential housing instability, and all of this impacts a patient's ability to get well. And with housing problems, again, it comes with financial problems, and of course, they kind of relates to the employment problem. And so again, we see it's a dangerous cycle and again, has an impact on a patient's ability to get well. So we also see denial of claims problems and end-of-life planning problems. So we see a lot of the time private insurance can refuse to cover cost of treatment, which puts an immense deal of stress on a patient. And then we also see Social Security disability if they have been denied, or if Medicaid has been denied. And a lot of the time, so when our patients are approved for disability, there is a 6-month window to actually get a check. So your bills are still coming in, and it takes a 6-month window to get money. So patients can be facing eviction or foreclosure, and they're just trying to choose between paying these bills and just living to get better. And also end of life planning documents is a huge thing. We don't see a lot of patients who they come in and they don't have these in place, and these can lead to legal difficulties, as well as it has a lasting effect on the loved ones left behind. So how is help provided? We have an intake and referral process. And so we see we get a lot of our referrals from our medical legal partnership, social workers, physicians, and other agencies. So we'll do the intake process, and then we will refer clients to our volunteer professionals, whether that be an attorney or a financial planner. Or clients may also see our client service attorney. She gives really good general advice. She can also do wills, power of attorneys, and advanced medical directives. And then we always do a follow-up with the client and the volunteer to making sure all needs are set. So a little statistics about our CancerLINC clients. So in our most recent fiscal year, which ran from July 1st of 2019 to June 30th of 2020, we have served 459 local cancer patients with 579 legal and financial issues. And so 79% of those patients we served, they do live below the federally defined poverty line. 59% of our patients served are 50 years and older. 62% of our clients are female. And 22% of our patients served had breast cancer, and that was our largest group. So and here is just a chart. We see that 50% of our patients, they needed the life planning documents. And 84% of our patients served said that CancerLINC services allowed them to focus more on their health. So what we do, here is a whole list of the things we do and what we don't do specifically. So we don't do criminal matters, divorce, contested guardianship, conservatorship, immigration law, personal injury law, medical malpractice law, and general contract law. And so we do also, I know I talked a lot about our legal resources, but we also have financial resources as well. We work with a great team of financial planners who are there to help our clients, again, for free, whether it be financial counseling or planning, credit consolidation, debt consolidation, and management of medical debt. Okay, so who can become a CancerLINC client? So any patient that walks through our door can get help from us. We want to ensure that no cancer patient goes without the needed support services, but we do have an income guideline if for the patients to get help for free. But if a client do, however, if they exceed those income guidelines, we will still provide them names of attorneys, and we will still give them those resources. So to talk a little bit more about our income guidelines for our pro bono services. So we do go by the urban housing and urban development income guidelines for Virginia, determine eligibility. And some of the other things we take and we assess is car, boats, trailers, motorcycles, real estate, bank investments, retirement savings, partial interest or ownership in a business, things like that is that we use to assess our guidelines. And we also, though, we do assist immediate family members for up to 2 years after a client's death. So, and what areas do we service? So again, we are a Central Virginia-based nonprofit, but that doesn't mean that we just help people in the Central Virginia area. If you are receiving care at a greater Richmond area cancer care practice, you can receive our services. But mainly we do help our cancer patients are in Richmond, Petersburg, Hopewell, and Colonial Heights. So we do have also fantastic free resources on our website. If you go to our resource page, we have a community resource packet. There you can see we have the names and numbers of other organizations. If it's a service that we do not provide, we want to make sure no cancer patient goes without those services. We also have our client brochure and informational flyers for volunteers. So if there is a volunteer attorney or a financial planner who would like to get more information, you can go to our resource page. And another really cool thing that we have is we have our online intake form. So if a patient doesn't have the time to come and come into our office or give us a call, they can do this all online at their convenience. And then we will give them a call as soon as we can so that they can receive our services. Okay, so how can you help? So we do provide a monthly e-newsletter if you would like to get some more information, support our fundraisers. We're all across on social media, things like that. So this is the end of my presentation. And if you would like to contact me or contact the office, we have all that information there below, 804-562-0371 for our main line. And if you want to get to me, my extension is 104. So thank you so much.
All right, Casey, thank you. And you're welcome to stop sharing your screen if you'd like.
Yeah, there you go.
Yeah, when I heard about CancerLINC, I just thought it was an incredibly valuable resource for a lot of the patients that we work with because, you know, someone gets diagnosed with cancer, that doesn't mean the rest of life stops.
Right.
So having an organization that is able to help with some of the more complicated practical things, I think is invaluable. So if any of you in the audience have questions for our panelists, please feel free to enter those in the chat. I do want to start with a question for Dr. Bellavance. So with your graph featuring the number of patients with metastatic breast cancer, that can be pretty daunting when you see the number go up year after year. But so what that graph is demonstrating is that's not necessarily the total number of patients who are diagnosed metastatic that year. It's the number of patients who are living with metastatic disease.
Exactly. Yeah.
So we want to see those numbers go up, more people being alive with the disease. Do we have numbers on how is the frequency of metastatic disease increasing, decreasing? Do we have those numbers as opposed to like year after year?
I don't have those numbers off the top of my head. When I initially presented the number of newly diagnosed breast cancer patients, about 6% of those cases will be metastatic disease. So that, meaning they're presenting initially with metastatic disease. So they make a smaller portion of those initial presenters. Again, the majority are going to be from patients who have had a recurrence. In some sense, you might see the numbers go up because our ability to detect metastatic disease over the past 10 years has improved. So there may be a subset of patients who, you know, we thought were treating much earlier disease, and they might have had a small lesion somewhere that was not picked up on, whereas today, you know, we're picking up on that earlier.
So that's good. It's nice to see that there has been some progress made in metastatic disease, even though we obviously need to put more money
We
in.
do need, well, yeah. That's, you know, the subset of the first patient I presented, that is a very unusual presentation. So I don't want to gloss over the situation by saying we have all of these patients we can, you know, who are living past 10 years. That's definitely a smaller proportion, and we need to keep that in mind that, you know, there's still a long way to go, but hopeful that things are changing.
Yeah, and there's actually some legislation that we're advocating for that sort of combines both of the subjects of your talks today, basically making it easier for metastatic breast cancer patients to access Social Security, disability, and Medicare, because, you know, by our numbers that we found, the average lifespan for someone who has metastatic disease is 26 months. And you know, it takes 2 years to be eligible for some of those benefits. So
Yeah.
really getting rid of that waiting period is going to be vital for these patients. And so Casey, I wanted to hit on something that you said too, talking more about your medical partnership with VCU Massey. So from what I understand, it's essentially one of your advocates has basically office hours at the Massey Cancer Center. And if patients are going in and out to see their doctors, they can walk by that table and just ask questions and set up appointments and things like that. Is that correct?
Oh, yeah. So with COVID-19, those hours are definitely changing. And so with all of that, things are changing. But if people want that advice, they can always just give us a call in and talk to our client services attorney, since those hours are changing. We hope to get back, but yeah, we used to have our attorney be on site 12 hours a week, which was, it's very vital.
Yeah, that's again, yeah, that makes sense. During COVID times, those things are a little bit different.
Yeah.
But I think that's an amazing resource because, you know, people are leaving the doctor and they have all these things floating in their brains, and then they pass by someone like, oh, we should probably do our wills, or we need to figure out some financial planning stuff because the bills are getting out of hand. And you have someone right there who can help point them in the right direction, which is wonderful.
Mm-hmm.
All righty. Well, I'm not seeing many questions in the chat, but if you will be sending an email to the, thank you. We do have one just echoing the Metastatic Breast Cancer Access to Care Act, which is that access to different resources, Medicare and Social Security disability that mentioned earlier. So yes, we are working on that. And all the attendees will be receiving an email with more information about both of our panelists and the CancerLINC website, Virginia Cancer Institute website. So thank you both so much for your time. And thank you to all of you for following us for More Than a Pink Ribbon webinar series this month. We really appreciate it.
Thank you.
Thank you.